Well, you've certainly been hearing a lot about the face and about the kind of wonderful things that can be done now and how everything has improved in terms of facial surgery. As a psychiatrist and a researcher, what I'm looking at is really going behind the face. And of course, behind the face, of course, we have a person. And having facial surgery, whether it's for trauma or for cancer, is an extremely stressful event. And the kind of research questions that we're asking, one of the main questions is, are all people going to experience psychological distress? And when I talk about psychological distress, I'm thinking of disorders like anxiety, depression, and a more severe sort of anxiety, which is post-traumatic stress disorder, which happens when you have a severe stressor. So are all people affected? And the bottom line, of course, is, does psychological distress actually affect the prognosis and the treatment outcome following facial surgery? So our first question, are all people who are undergoing facial surgery going to experience psychological distress? We've looked at large groups of patients. If we look at people who've experienced trauma, this is a group of 220 patients with trauma. You can see that about over 20% are actually suffering from acute stress. And acute stress at these levels is highly predictive of post-traumatic stress disorder occurring several months later. We have about 30% who have depressive symptoms, and then a higher group that have anxiety symptoms. And there's a lot of overlap in these conditions. This is just some of the data that I'm showing, and there's a poster out there if you're interested in the kind of things that predict who's going to have these sort of reactions. But you can see straight away it's not everybody. It's a certain group of people who are going on to experience psychological distress. If we look at cancer patients, here we have different populations of cancer patients, and we're looking at high levels of depressive symptoms. And these are head and neck cancer patients, these are colorectal patients, these are patients with breast cancer. And it's about 20% of people with head and neck cancer who are experiencing depressive symptoms. So again, it's not everybody. And people intuitively think that head and neck cancer, there's going to be more distress. But in fact, that's not what we see in the clinics. So the next question is, does psychological distress affect prognosis and treatment outcome for these patients? And I'm going to be talking not just about survival, but about the outcome of quality of life, which is our measure. And the kind of study that we did, one study that we did at Barts and London in Ian's clinic, was we were looking at people coming in newly diagnosed. So these are patients coming in, being diagnosed with cancer, and they have surgery very quickly afterwards. So there's only a very short time when we can look at this. And what we asked people to do was complete validated questionnaires, asking them about depression, anxiety, stress, their quality of life. We also asked them about past experiences of stress. And then we also took blood samples, and we were actually measuring biological markers. In this instance, we were measuring inflammatory markers to look at the levels of inflammation at baseline. We then saw the same patients a week later, 4 weeks later, 3 months, and 6 months later, and they completed a series of questionnaires as they went through, and also we took more biological samples. And we had 90 patients who completed this study. So a fair-sized group, but not an enormous group. And I haven't got time to show you all the data, but one of the most striking things was that when we looked at quality of life, what was really associated with poorer quality of life were depressive symptoms, not functional and physical symptoms. So these were people who were coming in, they might have had a small lesion, they had this major surgery where half their jaw was being removed, they were going into intensive care, they couldn't sleep, they couldn't swallow, but what caused them to have poorer quality of life was not the extent of the surgery, but whether they had depressive symptoms. So that's what our patients were identifying as affecting their quality of life. The other thing that we found, which again was striking, was that we were looking at inflammatory markers. And those people who had higher levels of inflammatory markers at diagnosis were much more likely to have poorer quality of life at 6 months. And we know that high levels of inflammation are associated with depression and with stress. Now, inflammation is something that is the body's natural response to injury, and it's a natural response to cancer. But when you have high levels of inflammation, they can be very damaging. So it's an important factor, and it appears to be something that is predictive. But of course, we're talking now about the person, but behind the person, we have the family. And we're also interested in looking at not just the effect on the family, but what effect the family has on the patient. And does it have an effect on patients' outcome and their response to treatment? And the kind of information that we get from our patients are that it's a very distressing time. This head and neck cancer patient saying, I think it's more stressful for my wife. I'm sure that she's devastated by his diagnosis of oral cancer. So Faris Shiraz has been looking at this in a group of patients with head and neck cancer. And this is the data from patients who are coming in. This is at diagnosis. You can see that we've got this sort of level of depression. About 16% of them have high levels of depression. 40% have high levels of anxiety. The blue ones are the patients, red ones are partners. So at diagnosis, there's the same that we usually find. But the partners have higher levels, much higher levels. And when we look at 6 months, again, the patients have a certain level, but the partners have higher levels. And when we look at the relationship between the partners' levels of psychological distress and the effect on the patient, what we're finding is that patients whose partners are distressed have poorer quality of life. So that's something that's important, where we can make an intervention both to help partners and families, but ultimately to help our patients have a better outcome. But of course, behind the family, there's a much wider social network. And we have behind the family the society and the support networks that people have. And we're looking in quite a lot of detail at that. But in our work so far, something that's very striking is that patients with poor social support have poorer quality of life and treatment outcome. We actually know that loneliness is a very powerful stressor. So people who are lonely are under a great deal of stress. And we know that stress is something that increases inflammation, and we know that's not good. But one thing that we weren't expecting to get from our study, because it was a study of 90 people, it wasn't a very large study, but what came over statistically significantly was that those patients who had a history of childhood adversity had poorer quality of life, and they had higher levels of inflammation. So there was a biological effect. Those children who were under adverse circumstances had suffered bullying 30, 40 years prior to their cancer diagnosis. It was making an impact on their treatment outcome, on their quality of life presently with their cancer. So what's the point of our prospective clinical studies? What we're going to use all these data for? The bottom line is that we want to improve treatment outcome. We want to be able to identify those people who are vulnerable to the effects of stress and who are likely to suffer poor quality of life. And the point of that is that we can deliver appropriate early treatment interventions for patients and their families. And that's something that we have underway now. We're introducing a multimodal type of therapy so that what we can look at is the kind of problems that people have, if it's high anxiety or whether it's fatigue and depression. We can deliver different kinds of psychotherapies, cognitive behavioral therapies. That's together with exercise therapy for those who have fatigue, but we can introduce those at quite an early stage. We can provide support for the families that's going to be appropriate. But of course, another thing that we need to do is there are children out there now suffering from adversity, and those children are going to have more problems when they have chronic illness or they end up being diagnosed with cancer. So I'm going to just say thank you to my co-researchers, of course, and to Saving Faces who supported us, but most of all to our patients, because they came in at an incredibly stressful time of their life when they were diagnosed with cancer, and on day one they were taking part in our studies and giving us those very important data samples so that we continue this work, hopefully, with NFORC. Thank you very much.